Uzmanību, uzmanību, kolēģi! Dear doctors, dear friends, dear ladies and gentlemen, it is my pleasure to welcome you all to 12.Baltijas Association of Dermatovenerologu Congress. For your information, we have registered near 300 doctors, some 200 and half was today, and some will come tomorrow from Estonia and other more for sexual transmitted disease. I thank you all speakers or participants about coming here, and also companies about sponsoring us, and all other doctors. And now I can give floor to our rector of our university, Professor Academic Marcis Auziņš, for welcome message. Please.
Honorable Professor Rubins, dear colleagues, dear friends, first of all, good evening. I am very happy to welcome all of you to the University of Latvia, to large aula of the University of Latvia, which is the main hall of our university, and we are organizing here only very important events. And of course, today your Congress, the 12th Congress of Dermatovenerologists, for this it's even hard to pronounce it. So it means, and I understand that it will be really high-level discussions today in this hall. But before we are starting discussions, I think that it would be nice if I will give you some general overview about our university. And the University of Latvia was founded in 1919. It means that this summer we will be celebrating 95th anniversary of our university. And for European scale, it sounds like not very old university. But actually, in Latvia, university cannot be older than that. If we are speaking about national university, and we are national university, we are the first national university in Latvia and the first research institution. And it was founded only a couple of months after independent country was founded. So it means that it's we are the oldest age which is possible for national university in Latvia. Currently we have around 16,000–17,000 students. When I'm so uncertain because we have now graduation time and number of students are changing on the hourly basis. Again, for European scale it sounds like a medium-sized university, but if I am willing to impress my guests, I always say, look, it's almost 1% of current population of Latvia. And that's true. Probably it tells something not only about university, but about country in general. We are a small country. We have roughly 2 million inhabitants, and it means that we are playing a really important role in our country. And this position of the University of Latvia, in some sense, is reflected in our slogan, "Scientia in Patria." Unfortunately, when we have congresses, very often it's half blocked by our screen there. But you can imagine that there's a Latin saying, "Scientia in Patria," it means that for science and for fatherland. Again, it reflects that we are not only research university, but we are playing very important role in society in general. And I guess that your Congress today also is important not only for professionals, not only for medical doctors and for researchers, but for general public as well. Because healthcare is always an issue which is debated not only among professionals, but among society in general. And Latvia is not an exception. Currently in Latvia about different health issues and healthcare issues we are debating almost constantly. As I said, the University of Latvia is a research university, And it's not always easy to measure research output, but there's one way how we can do that. We can calculate how many publications in high-level research journals, and you being researchers, you know that there's very precise definition what means high-level research journals, what kind of databases we should look in, and all of that. And if we are measuring research output in this way, then the University of Latvia is contributing more than 50% of all the research output which is coming from Latvia. Of course, I'm counting our research institutes as well, not only departments. Another way to look at the research output is to count the number of PhD students, how many PhD degrees are offered by university. And if we are looking in this way, again, the University of Latvia is granting each year more than 50% of all the PhD degrees which students are receiving in Latvia. I think that these two quantitative measures reflects what kind of university currently we are. And coming back to your Congress, as I said, I am very happy to welcome all of you to the University of Latvia. I am sure that in this lecture hall during this day you already had, and we will have tomorrow very important academic discussions. But my next wish probably will be a little bit unusual. I am wishing you to have a lot of coffee breaks and a lot of social events. And I'm wishing this for very concrete purpose. Because in my experience, being physicist, during these coffee breaks and during these social events, sometimes even more important discussions are happening than during the official talks, and more relaxed and more open discussions. And if this will be happening during your Congress, I will be more than happy. And I'm hoping that during these discussions, maybe some new contacts will be established, maybe new collaborations will start, and if some new projects will be submitted and if they will be funded, I will be more than happy. So I really wish you a very happy, very successful Congress. And besides, I hope that the weather will be good. In Baltic states you never know, but I hope so. And then you will be able also to explore our beautiful city. So all the success to your Congress. Thank you.
Thank you very much, Rector, about kind words and welcome message to us. And now we will ask Latvian three tenors for welcome message.
Quelle che senti nel cuore, lanze dei baci fiori, quelle che cerchi l'amore, come il supremo desio. Quella che senti nel cuore, lanze dei baci fiori, quella che cerchi l'amore, come il supremo desio.
Si
scocci dalla Spagna, io vedo te. Tirate con le monete tobacco, in ciel si va. In ciel si va. Si va, secondo il vento va lo scocco, e si angela, e si angela. Yamma, 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 yamma. Monicoli, monicolo, monicoli, monicolo, yamma, 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 monicoli, monicolo. Monicoli, monicolo, monicoli, monicolo, yamma, 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 monicoli, monicolo.
Dear colleagues, before I give word to Professor Alfanos, Professor Arifov from Uzbekistan, I want to tell some words. Because our president now is in Uzbekistan, and can't go in this visit to Uzbekistan at this time because I have Congress. Please tell what you...
First of all, I said welcome to Congress, very excellent organizer, and today Vinci, and I say it is your first, for example, celebration day. I see you are happy, see your guests from many countries, and we change it with information. And you know, maybe don't know, Uzbek people going to Gust couldn't go without some present. It is our habit. And for this, I want to give Baltijas Association personally to Andres Rubens, to our Samarkand picture. Можете с близкого расстояния фотографировать? Близко. Да, это для меня, что показать. Вот. Это вам. It is famous place called Registan. Registan. It is in many people coming to see it is acoustic is very nice. It is for you.
We are ready to come to Uzbekistan.
And next one. Just this. Today, Andres Rubens, and every time he is king. Today, a special king. And king should wear a king overcoat. On those of us in Korolevsky flag at that overcoat. And for this, I want to give him.
It's not so easy. Professor Constantine Alfanos, he is not only honorary member of Baltic Association, he is one of well-known professor, the best speaker in the world. He was before main in the Germany, and now too. He is president of Berlin Foundation. He was general secretary of World Congress many years ago, and now last 10 years he do all more in Africa. And this lecture, as you can see, is his experiments, 10 years experiments about Africa. Welcome, Professor. Floor is yours.
Thank you, Mr. King. Thank you. Yes. And congratulations, Andres, for this honor. I think you deserve it. Now, ladies and gentlemen, thank you. Now, ladies and gentlemen, I want to give you today a short impression of our experiences during the last 10 years. We have spent visiting, offering medical services and medical advice in African countries. After being emeritus from the Berlin University, we had quite a few students in Africa, and I contacted them and decided to be of some help as an old man. So, dear Andres, I'm not going to present experiments today. I'm going to present experiences. In these experiences, I must say, they have opened my view. They have increased my knowledge. They have sensitized my perception about what's dermatology about, what is being a physician, offering medical services to people who need them. So, and also, these experiences, they have sensitized my perception about the ethical requirements we have as physicians. And not only ourselves, but also our representatives, our global players in dermatology worldwide. So, going to Africa as a European physician, you think you are going to give them your knowledge and help. You do so. But when you come back, you feel yourself enriched, having the broad view about what you're doing and about what you can do. The question is, can we do something for these people who are needing medical care, dermatological care? The answer is yes, we can. And the second question is, can we afford to offer our help? And in spite of having a lot of problems in our countries, all of us in Latvia and also in Germany, which is considered to be rich, yes, we can afford. First of all, before to show you a little bit of my experiences there, by the way, I should say, with me was also my wife, who is sitting there in the front row. She is also a dermatologist, and she was contributed to my happiness being in Africa without telephone and without radio and without TV and without all these facilities which we regard and consider to be a precondition for happiness, which are not, definitely not. All right, let us see now. This is Africa, and our experiences, we have collected them in 4 areas of this continent: in Egypt, in Uganda, in Tanzania, and in Namibia. So through the continent, most of them, of course, they have been collected in the area of what they are calling Black Belt of Africa, in Central Africa, in Uganda and Tanzania. So one has to know that Africa is the second largest continent and the poorest of all. If you see the WHO list of countries, the poorest countries are in this continent, according to that scale. There is a lack of facilities. In Tanzania, with 38 million, or now perhaps closely 40 million people, there are only 5 dermatologists, and there are 2 gastroenterologists. There are a lack of facilities. There are 3 large hospitals only in that country that are covering the medical disciplines. And in these hospitals, they educate some of their people, but most of them, every year, they leave the continent looking what we call the green pastures somewhere around Europe, United States, Asia. For us dermatologists, it's important that in these countries, skin diseases are common. They are due to the socioeconomic conditions, the climatic conditions. We have a series of skin diseases. It is not something that is, let us say, lying aside. And the training facilities are very poor. The dermatological skin care is definitely neglected. So these are 4 basic points we have to keep in our mind. Now, what about medical care in Africa? The African population is a little bit more than 1 billion people. Most of them are young people and children. Africa means children. You realize that when you come to these sub-Saharan countries, to the Black Belt, particularly to see. And according to the statistic of the WHO, you see here 1 physician per 100. In Germany, there are about 1 physician for 380 or something like that. In India, worldwide, 1 to 4,000, and in Sub-Sahara, 1 to 25 to 50,000 people. Of course, the people, they also prefer, for the first time, to go then to the village doctor, who is actually a traditional herbalist. Some of them, they are what we call them witch doctors. They're doing a lot of mystic, esoteric, witch-like actions to influence diseases, particularly skin disease, when they see it, because in other cases they have to diagnose, and this is, of course, difficult. So if somebody goes to Africa, has to know the conditions, has to understand the people, has to understand their feelings, why they go to the herbalist, to the village doctor, to the witch doctor, because they are cheap, of course. They cost about 10 cents or 20 cents. And to go to a traditional, to a real doctor, it's called $4. $4, that is about half the wage for a week for a simple worker in the rural areas. So he needs to know about traditional medicine, about physical medicine, about their personalities and their feelings. The Africans are not what we think they are by seeing them here. In their own countries, they are different. They have a very warm social community around them. And when they come here, they feel to be in a very cold environment, and they react totally different. So the social connection, interaction in these countries is much, much better and closer than in our countries. So what are the skin diseases in these hot climate zones? Of course, infections are in the first row. Why? Because the interaction between people is close. The life is taking place outside of the houses, and they are getting close together. they don't have a hesitation to touch the other, to take him in their arms. So this is at least an explanation. And of course, the hot climate zone and the climatic conditions, the high humidity, they are promoting infections, all type of infections. I'm going to show you some of them. Of course, we see also classical dermatosis, lichen and psoriasis and this kind of thing. And another thing you're going to see are genodermatoses. There are two of them that are quite common in Africa, which are less common here. And what is surprising is that tumors are less. They are less prominent in their incidence prevalence in these countries. Why it is so, that's a different kind of thing. One has to work on it to understand. So skin tumors are more rare, except the tumors that are seen associated with HIV infection. So what are the commonly seen disorders, except those? Insect bites of all types. In East Africa, there is a very common, or quite common, insect bite, the Nairobi fly, and there you see vasculitis-like changes. Parasitosis, infestations with scabies, worms, amoeba, filariasis. Amoeba and worms, they are perhaps, this is a judgment, I'm not sure whether it is correct, but I would say, according to my experiences, 10% of the population is infestated. So if you have, let us say, a disease and you have to give corticosteroids, you have to think about that this person may be infested with worms and amoeba, and then you have a generalized infestation with amoeba, and the patient may die. So one has to do something together with corticosteroids if you think you have to apply. And of course, sexual transmitted infections. This is a major point of interest, a major point one has to take care in Africa, including, of course, HIV infection. So these are the points that are prominent, and there are some others that are less prominent. For example, diseases of pregnancy, all type of pregnancy exanthemas. Although in Africa they are lacking. I have seen one or two during several months of being there, several weeks every year, months sometimes. So diseases of pregnancy are lacking, although an average African woman in the black belt again has about 4 to 5 pregnancies, even more, some of them 10, about at the average 4 to 5 every year. You see no exanthemas of the pregnancy. I don't know why it is so. Of course, you don't see melanomas, only acrolocalized, very few cases, and although humidity and let us say the surrounding could be quite promoting the presence of borreliosis, there is no infestation of borreliosis. I've seen none of them over the period I was there. Some people believe there is, but I haven't seen. So, what are the basic experiences? If a European dermatologist goes there, he has to understand that the situation is different. The incidence of prevalence of the diseases there is different. The clinical picture may be unusual because African skin is different. There are ethnic differences of skin between Caucasian skin, African skin, and also between, of course, Asian skin. There are differences. And I must say there are very few experimental works done on this. There are very few investigations for young people who are working globalized, worldwide. That would be something to do to find out the differences between the ethnic skin. So the clinical picture may be unusual due to the ethnic differences, due to the climate conditions, due to the UV exposure, and so on. So the European dermatologist, even if he is experienced, he has at the beginning some difficulties, also because he doesn't see erythema. He doesn't see, let us say, the bluish color of some vasculitis lesions. He doesn't see the erythema in urticaria. He doesn't see the signs of, or a major sign of inflammation. And of course, the clinical courses and responses of the people according to their feelings, to their traditional customs and habits may be different also because of the different health conditions. So that's why one has at the beginning difficulties. The thing that is coming up and that makes perhaps, facilitates perhaps some diagnosis is that the cases are clear-cut, they are progressed. And they are progressed. Why? They are progressed because the people have to go long distances, and they have to decide to go a long distance to see a physician if they see. As I said, for example, in Tanzania, there are 3 big centers, or medical centers, as we call them here, in Dar es Salaam, in Dodoma, and in Moshi. And we had patients that were coming from 300, 400 kilometers from long distances to see us for once a day and then go back to their villages and their homes. So the cases are progressed, and what I'm going to do is to show you some of them to understand a little bit the clinical picture you have to expect. For example, here you see impetigo, progressed, ulcerous, with fever, quite generalized in a child, and you see here staphylococcal infection in the breast of feeding a woman. This is something that you may of course treat with antibiotics quite nicely. Antibiotics are available. I must say this is something that we are very grateful for that antibiotics can be bought, they are not expensive, and they work. So, but there are some other cases, for example, varicella zoster infection, generalized, disseminated in this child, covering all over the body, and of course, the child was also infested with amoeba, and it was immune suppressed. The cells were reduced 300 to 400, so it was quite a life-threatening situation. And of course, zoster in HIV patients are severe, bullous, hemorrhagic, sometimes ulcerous, and of course, acyclovir and this kind of drugs are available but are expensive. And the other viral infection, which you see here, the giant condylomas, the giant genital warts, you can see in young women, 17, 18, 19 years old, difficult cases to be treated, clear-cut to be diagnosed, of course. So progressed cases of infection, HPV infection of all types, are seen in all areas, both in the north, also in the south, and of course in the Black Belt. One important and difficult to understand point is the eczematous reaction in the African skin. It seems that if you have an eczema, the reaction takes place in the interfollicular epidermis. There you have the accumulation of lymphocytes and whatsoever. There you have the eczematous changes in the epidermis. In the African skin, you have at the beginning, before there is any infestation, staphylococcal infection whatsoever, you have a reaction of the follicular epithelium around the follicles. And as you see here, this is a follicular reaction, acute, and also in a chronic, in an atopic person. And this is something that the people who are working in Africa, they know, and they call it follicular eczematous reaction in African skin. One has to know that, because we would have another diagnosis in the European skin. In African skin is a classical picture, the follicular eczematous reaction, not only in acute contact eczema, but also in atopic dermatitis. You may see this kind of changes. And for example, here you can see in the atopic personality, you can see this follicular erythematous. Actually, in some cases, you can see the erythematous follicular reaction. So this is eczema in African skin, quite different from what we know in our areas. And of course, this eczema in chronic cases can be changed and can be, after some irritation, can be keloidal. And you see this kind of follicular eczema in the flexural areas with some keloidal reaction. Something quite new, one has to know, to understand, and to be able to treat. Such a case in European skin could be most likely easy to diagnose if we would know whether there is an erythema together with the scales and what kind of color the erythema would have. In African skin, you can help yourself by seeing here a Koebner phenomenon, and also by looking at the mucosa. And then this case was diagnosed only because we found here the changes of the hyperpigmented lichen planus, the tropical variants in pigmented skin. So not easy to diagnose. And psoriasis is actually not a big problem. There is also 1 to 2% of the population has psoriasis. They are exposed to UV radiation, of course, in psoriasis cases of the severe type. We see here erythroderma, pustular, and so on. You don't see it in Africa, but you see the classical vulgar psoriasis. And what is important is that in some cases, you don't have, if you treat psoriasis, and you have then what we call post-psoriatic leukoderma. In African skin, you are going to find a post-psoriatic melanoderma. And you see it in some cases that have been treated. Here on that side, it is a Maasai from Tanzania, and he has been treated with a topical and also with methotrexate in that case. And then you see that there is a melanoderma in the areas. The lesion is flat, there is no scale, there is nothing, no infiltration, but there is a melanoderma indicating, it is difficult to see in this screen, you can see it much, much better in other screens. But you see here the melanoderma as a remnant from the psoriasis he has had. Now this is one of the most interesting, also scientifically interesting cases that I have seen. There are cases that are coming, not very common, but they come from time to time having this type of appearance, and if you look carefully, you see that this is a bullous disease. You don't understand quite well what it is. In some cases, we have found that this disease is corresponding to the Fogos alvagam, Pemphigus foliaceus, that is seen in Brasilia and in South Africa, in South America in general. It's not described Fogos alvagam in Africa, but I'm quite sure that these cases are corresponding to that disease, and you know that there is a very particular pathogenesis for Pemphigus foliaceus, and it is related to some insects from the rivers. And indeed, in some of those cases, we went to their villages and we found that they are coming from the slopes of the Kilimanjaro or villages close to water. And this is the same thing is actually in South America. So if I would be a younger man, would have much more facilities, I would go there and collect those cases, and I would call them the African Pemphigus foliaceus from the northern Tanzania and also Uganda area. very interesting cases, very interesting to be seen, and they seem to be endemic in East Africa particularly. I haven't seen them anywhere else. They require a certain environment. In African skin, you see several times drug eruptions of all types. I cannot show you all the pictures, but they are phototoxic, particularly due to anti-malaria drugs, also to doxycycline, also to diuretic drugs, Lasix and this kind of thing. You see phototoxic drug eruptions which are connected with strong hyperpigmentation of the face, as you see here. It is quite clear. Here is the normal skin of that person, which is not so black, and here she looks like an Ugandan person from a rural area. So drug eruptions are quite common. Another thing that is, of course, sometimes to be considered is the differential diagnosis. If we would see this ulcer in our area, we would say perhaps it's an ulcer from cruris of some type. In Africa, one has to consider that this may have a different etiology. Also, this edema here, it could be an erysipelas in our area, and in Africa, sickle cell anemia is the most common reason or connected with this kind of sharply demarcated ulcer on the legs. And of course, in cases which may suggest erysipelas in our area, particularly in the hot climate zone of Central Africa, they may suggest filariasis as the underlying condition. Now, this case was a man who was 1 year or so in treatment in a village by a traditional witch doctor, and he thought perhaps he had psoriasis. The fact is, in this case, we did some histology. Histology is not easy. The most lacking facility in poor countries in the developing world is dermatopathology. The people are not experienced, they don't have the facilities. In this case, we sent the histology and also to Nairobi, and it was leprosy. So, lepromatous leprosy. Leprosy may occur in Tanzania, it may occur in Uganda, very little also in Kenya, also in Egypt, in southern Egypt, from Sudan coming up. Few cases, it's still there, the disease. The lady of the tropical areas, it's still there, and the thing is that the taking care of the lepromatous people are not dermatologists. They are epidemiologists from the WHO. They have a certain centers, and they do a good work in terms of treating diagnosed diseases, but they're not diagnosed cases. But they're not able to diagnose newly appearing lepromatous cases. And that's the problem. So there are a series of new cases of leprosy, although the WHO had its goal to eliminate leprosy by the year 2000. Unfortunately, that's not the case. Leprosy is still there, particularly new cases, and they are treated, of course, properly. Must say this works quite nicely. So one major point, there is another one, but this is the fungal diseases in the tropics. And you have all types of this. I think we know not that much about the severe cases of fungal infection. There are cases with dermatophytes, there are yeasts and molds, and all of them, they are connected, or at least the yeasts and molds, they are connected with the generalized, deeply localized mucocutaneous diseases, deep mycosis. And the areas I'm talking about, we have seen all of them actually. Cryptococcus, histoplasma, and Candida, generalized Candida. Cryptococcosis usually comes with HIV infection. And also Madurella mycetomatis, which is actually more or less, we think it is more or less oriented towards the east, the Arabic Peninsula. It's not the case. It's also in East Africa. I'm going to show you some of these cases, and also deep mycosis. We have seen only one case of aspergillosis, but all the others are there. So what is most common is the superficial tinea of the scalp. Usually we have in our areas tinea of the body. In Africa you have all types of tinea of the scalp that may be superficial, they may develop, may become large and deeper, and then you may have a deep super-infected connection. We didn't have the possibility to differentiate what kind of trichophyton was there, but I think all types may occur. The major thing is this tinea capitis that is occurring particularly in the schools. We have been in some rural schools, and about 10 to 20% of the young boys that have this quite particular type of tinea capitis, which we call the African type, because it's disseminated, it is slightly scaly, it has no erythema, and it is also causing some atrophy between the hair follicles. So most likely the infection is transferred by combs and barbers. If you go to Africa, you rather cut your hair yourself at home. You don't go to a barber shop because you don't know exactly what is happening there. And by the way, when I came back to Germany, I asked my barber how often he disinfects his comb. And the answers I got were actually not very satisfying, I should say. So, candidiasis, cryptococcosis, as I said, with HIV infection, histoplasmosis, chromomycosis, and the Madurella mycetomatis, all types, the U mycetoma and pseudomycetoma, some of the phaeohyphomycosis. We have seen a little bit of sporotrichosis, and the other ones are aspergillosis, are absent. This is a very typical case of verrucous chromoblastomycosis, which is not very rare, may occur and may be chronic and may cause ulcering and so on. So this is something you have to see, you can see and you can diagnose, particularly because of the verrucous appearance of these lesions at the beginning. This is something that you may perhaps think it's mollusca. It is the typical case of a superficial cryptococcosis in an HIV-infected female. If you see them a little bit closely, then you realize they don't have the classical appearance. They are just roundish and they grow slowly. The basic threat of cryptococcosis is not the skin, cutaneous cryptococcosis, it is the brain cryptococcosis that may be an end to the HIV-infected population. And, of course, deep mycosis in children. It is something that is showing the last years an increasing incidence, most likely in these cases histoplasmosis, particularly in the flat savanna, dry areas of the Central African area. So this is one of my first cases, the first or second time I was there. I didn't have the slightest idea what it is. And I must say, histopathology, we didn't have it. I must say, I missed the case, but I photographed it. And after having some experience, some years later, I said, this was a Madurella infection, an early Madurella infection. What is Madurella? Is an agent that is located sometimes in the thorns of when they go without shoes on the fields. Then they incubate this agent, and then you have not painful, asymptomatic, as to say, nodes that are growing slowly. And in very developed cases, you have sometimes these giant tumors, and then you can diagnose them according to their appearance. Particularly, unfortunately, you cannot see it. Here you see black dots, which are very typical for Madurella infection. Here you see these black dots. They're very clear indication. There are accumulation of Madurella in some areas. They are quite clear, the diagnostic criterion for Madurella. Now, if these cases are growing exophytic, it's not a big problem, but if they go down, they are destructive. They are destructive and they destroy the bones. So the only solution for these cases, one has to do some X-ray and see what is happening with the skeletal involvement. If there is skeletal involvement, there is no treatment, only leg amputation is the solution. And this may be, of course, you understand, a big problem. So one has to treat the early cases. And I still remember I missed my first case, this young boy. I don't know what happened to him. Let us see. Perhaps you can see it better here, these small dots. Okay, a major issue in Africa, I'm coming close to the end. A major issue in Africa is, of course, STD and HIV-associated skin diseases. The leading symptom is pruritus. And I would say these are judgments again, but a lot of experienced people who have been there know that about 20 to 25% of our patients in the ambulance are infected with HIV, leading symptom pruritus. But of course, bacterial and fungal infections of all types, viral infections, and also superficial and deep mycosis are a reason to do the test. Till 2006, it was not possible to do the test. The people had to pay. Now I must say, and we are very thankful, we have been very thankful, the test is free, can be done, and it is, of course, of great help. Tumors, Kaposi sarcomas, lymphomas, and carcinomas are seen in this type of the population. And HIV-associated KS, as you know, it is the most common tumor in some areas in Black Africa, and the second common in women after cervix carcinoma. These data are coming from Botswana, but they are also valid for Uganda and Tanzania. So if it is interesting with the HIV infection, I'm going to show you a little bit epidemiological data. The Northern African Muslim countries are having very low incidence of HIV. Of course, it is more than the official data say, but still quite low. And you see here that the incidence is, and prevalence is increasing going to the south. And we have dealt with this data a little bit during the time in Africa. I had time, I collected the data, and it seems that the focus of the infection is in that area in South Africa, and from there the distribution is going up and is overlapping with the Central African type of Kaposi sarcoma, which was there before. So the HIV infection, I mean, this is important. Why? Because nobody knows exactly where the HIV infection comes from. Some people, I don't want now to say names, some people, some organizations suggest that HIV infection came from Africa. From my point of view, is that the HIV infection came from outside of Africa, from a harbor here in South Africa and has distributed over that area. So this is historically perhaps interesting. Now we see the cases, we see the results, we see both the acrolocalized Kaposi sarcoma in males, and what we see in Africa is the Kaposi sarcoma in females. And it seems that females are less resistant to Kaposi sarcoma. I don't know why. They have more often a distribution of the Kaposi sarcoma easily, and if we would have data on this, I would say even more rapidly. So Kaposi sarcoma in females is quite common, and that was a surprise when we went there. Because being in Berlin, I was involved with Kaposi sarcoma. I knew the Kaposi sarcoma. We had about 300, 400 cases of Kaposi sarcoma. We had only 2 women, 2 females, and then going in Africa, I saw exactly the opposite. And the interesting point is that the most newly infected individuals in Africa are females. If you see here this data, there is worldwide more or less equal numbers concerning the relation males-females. If you see the South Africa, the sub-Saharan countries, you see a prevalence of the females 40 to 60%, and if you have some, if you look at some studies from Africa, seeing and analyzing the new cases are between the 15 and 25 years old in sub-Saharan country are more women. So women are most sensitive to the infection, and the course is also different. It's more rapid. It seems, let us say, broad words, more malignant, and this is what we call feminization of AIDS. Now, is feminization of AIDS something important? Yes, it is, because here you see 2 cases. You have both cases of exophytic acrolocalized Kaposi sarcoma, and you have also this was a nurse. She was a nurse in a hospital in Tanga in East Africa on the coast, and came to us to Kilimanjaro Hospital to be seen and be treated. So feminization of AIDS, why so? There are some peculiarities about that. Females in Africa are unable to force the males to use the condoms. We can talk for hours about that, why it's so. The risk of infection is increased due to the high mucosal susceptibility. And there are some people who believe that the vulgar mucosa, perhaps this is something for people who are dealing with vulvar diseases, Sylvestris, for example, to look at the number of Langerhans cells, whether it varies in ethnical skin. And it seems that some people say there are more Langerhans cells there, and so the infection can be transmitted more easily. This is not quite well known. Some others believe that there are more aggressive HIV variants, and some others say the incidence of sexual transmitted diseases of other type, gonorrhea and whatever, that is much more higher in Africa, and for that reason the mucosa is more sensitive. So this is something that is quite important, and it has tremendous implications, because the risk also of vertical transmission is increased during the pregnancies, the high number of pregnancies, the high number of births, and because the African woman uses to lactate for 2 to 3 years. Why so? Is it a traditional habit to do so, first, and secondly, it is cheap. It is cheap to lactate for 3 years. This is what is recommended also by the WHO, 2 to 3 years lactation. You don't have to buy the food for the babies, which we do here, and they cannot afford to buy, so they lactate their children long time, and the risk of of infestation and transmission is, of course, high. So feminization of children, feminization of AIDS in Africa is a big problem also for the WHO. There are some programs to analyze and to deal with it, but the situation is still not satisfactory. At the end, I want to show you some genodermatoses. There are 2 genodermatoses in Africa, which we see more often than here. One is the albinism, and you see albinos in the streets, and you can diagnose, of course, from some particular features. I cannot go on today. I can give you another talk perhaps on albinos and albinism in Africa. This is a typical African albinism, and you see there you see precancerosis, actinic keratosis, Bowen's disease, whatsoever. This is the oculocutaneous albinism type 2, which is quite common, or what characteristic for the African population. We have been in schools in a rural area, and we found there 4 children with albinism, and one of them was with them, but he did not have an albinism. He had the other type of genodermatosis, a secondary school in Kilimanjaro district. And here you see the second genodermatosis that you can study and see in Africa, quite not common, but occasionally comes, perhaps every 3rd month, 2nd month. You can see 10 cases a year or so. What we did with those cases, sun protection. We gave them glasses, sunglasses, we gave them some hats, examined them for excluding some precancerosis, hats, sunglasses, and sunscreens. And if you realize that one package of sunscreen cost $5, then you can understand that this has been a wonderful, a precious gift for them. So we could do something, and we were happy to do it, and we were awarded by the thankfulness of these people, and also most of us who have been in Africa, they still remember the African smile, which is so strong and so empathic that you get infected and you like it. And one of my sponsors and helpers was the Berlin Foundation of Dermatology. And of course, in Germany, we ask for donations to continue this work. Thank you so much for your attention.
I think all understand that this is perfect man and perfect lecture. And now auditorium, who wants to go to Africa? Help Africans, doctors. Show hands now, but here you go.
Well, I want to say that if some young person wants to go to Africa, not for 2 weeks and 3 weeks, but for 2 months, 3 months, or 6 months, then the Berlin Foundation is supporting people who want to engage themselves. If you go to Africa, then the African people are going to ask you, how long are you going to stay there? And if you say, well, I'm going to stay for 2 or 3 weeks, they say, he's a tourist. Let him go back. We don't need him. So one has to engage himself, to stay there and to suffer with them also.
Okay, thank you again.
Thank you.
No, two things. We all will go to get together, party in a cafeteria. But at first, I want to ask all who make photo together with Professor Alfanos, we can make here photo. Professor, we can make one photo together, all together, all together. Who want?